Perfect. Thank you. She's recording again.
Okay, perfect. No worries. So I'll just I'm not sure when we drop, so I'll just reorient us back to where we started. So we've opened the calculator for OU Med Center. Again, this was the annual 2022 calculator. And we're just looking over here at the different domain metrics. So within the mortality domain, we have the different metrics. What I was demoing is the ability to use the hyperlink to drive that metric back over to Builder. So I had clicked on cardiology, which then drove me into Report Builder. And again, if we scroll down the page, you'll see everything is populated based on that calculator. So the time frame mirrors that annual performance time frame. We have OU Med Center. So this is the one difference between using templates. When you use templates in the tool, you have to really make sure you check to see that the focus hospital is yours, because the templates were built differently. The calculator, if you're driving in from the calculator, your hospital should be populated there, but it doesn't hurt as a best practice to always check that before you run the report. And then at the bottom, this is where I was explaining, this cardiology is already restricted here. So we're only looking at encounters that fell into the cardiology service line. And again, those are based on the encounter definition of MSDRGs that roll up into cardiology. And then also we do look at those that have an expected value. From time to time in the tool, you will see encounters. It's very rare, but we do have encounters that are unable to have expected value calculated. Again, of the thousands of encounters you submit, it's rare that happens. But this filter allows us only to consider the ones that have an expected value in our scoring metric. So that's why you're seeing that. Okay, so I'm going to go back to the calculator. I'm just going to go back to my Excel document. I just wanted to be able to show you that functionality of how you can drive that over. If we keep scrolling down the left side, we go through each of those 6 domains that I mentioned. So the first is mortality. Now we're coming up on efficiency. Again, efficiency is our direct cost ODE index and our length of stay ODE index by those same service lines. And again, OU Med Center will be evaluated on 13 different service lines with their cohort, and Edmond will have 6. You'll see here different service lines. In safety, again, this is where we're pulling in those ARC metrics. So PSI 03, which are pressure ulcers. Boy, my brain is not remembering exactly everyone. I think 11 is respiratory, post-op respiratory. Okay. And then your NHSN metrics, your CAUTI, CLABSI, colorectal surgeries, SSIs, your HIST SSIs, and CDI. I want to pause here when we talk about NHSN in the Quality and Accountability Scorecard. You'll see behind it, it's the SIR rate. So what Vizient is pulling into the Q&A is not a roll-up of all your individual CAUTI, CLABSI events from the CDB that you see in Report Builder. What we're pulling in is we're actually extracting the file from NHSN that CMS pulls to calculate their SIR rates for their regulatory metrics. So I just want to call that out. You cannot look at SIR in Report Builder. You can only see SIR in the calculator here and on your annual scorecard itself. These next 2, and this really ties in again to that session we did yesterday that Dorothy spoke with you about resource manager, because this is pulling in quality metrics related to resource manager and resource utilization. So we're pulling together those patients who had a hypoglycemic event and still and had insulin associated, with that. We also have warfarin administration after a documented elevated INR. We're pulling in the resource manager data of a warfarin administration married with the lab data of someone having an elevated INR. And again, these metrics are all outlined in that PDF document as far as the specifics. Then we go into our effectiveness domain, which again is all that readmission data, which is your percent hospital readmissions, and then those excess days metrics or that EDAC information. We also have a couple of specific process around sepsis lactate draws and blood transfusions in patients that had a hemoglobin greater than 8. Those are 2 additional metrics in that effectiveness domain. Again, looking at the combination of quality and RM. Okay. And then those outpatient procedures, we showed that example in the scenario of the arthroscopies. Okay, here's your patient-centeredness data, and then we go into that equity data. And again, those are measures.
One thing you might want to point out to the folks on the call is that right now, if you look at this for admin, there will be no data under patient centeredness. It's still all showing up for OUMC.
Okay.
We're working at the data.
So the admin folks on the call didn't hear that. So right now, if you're opening an admin calculator, the data you're seeing for HCAP scores are actually the OU Med Center facility. No data, sorry. So no data. But that it's blank. So they're working to get that separate feed out so you can see admin data there. Thank you, sorry. All right, so we've kind of gone through those columns on the left. Let's start talking now, moving over to the right, looking within the workbook itself. So these first two kind of light pinkish columns, well, let me pause. Let me go back up to the very top. So the very top gives you sort of your overall look. So you'll see in 2021 what your annual rank was. Because you're all new to the CDB in that time frame, you didn't have an annual rank for the 2021 period, which would have been announced a year ago, September of 21. So, but what we were able to do was take your 2021 data once we did your backfill and apply the 2022 methodology and say, you know, this is what your predicted rank was, you know, at that time frame. And then what your overall 2022 current cumulative performance rank was. So the dark salmon is your overall rank for 2022 out of the possible rank number of hospitals. Don't let this discourage you. This is not uncommon. This is not uncommon when we see hospitals join the database. You're brand new to the database. This is not reflective of the quality of care you give, and people recognize this. This is in the context of the metrics that are specifically being looked at, and more to the point of yesterday's conversation around expected values. And really, do we have opportunities with our coding and documentation based on the Vizient methodologies to really capture best how sick our patients are, how likely they are to die in our hospital, how likely they are to have a longer length of stay, and how likely they are to have a higher direct cost, okay? So I don't wanna focus on the numbers. I wanna focus on how you can use this tool and help, you know, really leverage your work going forward. So coming back down into the main body of the calculator. So these first two major sections, again, in this 2021, you're going to see all blanks here because, again, you didn't have a historical perspective. What that basically does for hospitals that have been in the tool and what you'll see next year is what it is, your 2021, your historical look for all those metrics. You have your metric value, and then this next column, and I haven't gone into the details on this, and I probably won't because I'm not a statistician, but these are what we call Z-scores. So that we take that metric value and through a statistical process of normalization in a bell-shaped curve, you know, we normalize all the metric values for all the members in the cohort, and we do standard deviations from the mean. And I'm getting too deep in statistics that I shouldn't, and I'm treading on dangerous territory, but understand that it's the Z-score that we actually use for the scoring in the domain, not your metric value, it's that Z-score. From time to time, you'll see if there is a volume threshold, like we talked about yesterday. So using Vizient principles, if you have 25 cases or less in one of these service lines, you'll not be penalized for that. You'll get what's called a low volume score, and that low volume then redistributes the percent of the domain score for all the other metrics, right? So it's basically taking that one out of the mix and then just adds a little bit higher weight to each of the others where you do have enough volume. Again, you would see a rank there if you had been in this scorecard that performance year. This next light pink section now is doing kind of what I talked about earlier. It's saying, okay, these were our metric performance values for those metrics in the time frame, and let's apply the newest year's methodology. And what would the impact be on our domain rank and an overall score, you know, percent of our overall score based on that. So again, taking your historical data, applying the new methodology to it. When we get into this darker orange or salmon colored area, this is where we start to look at those quarterly views. So again, I have an annual scorecard open. With each period scorecard, that's where you'll see data populated. So when you get a period 1, you're going to just see this quarterly view 1 populate with your metric performance value. So your July, August, September performance for those. And then over here in the darker orange is where you're going to see then your current performance as it relates, for that time period. So again, this is an annual. So this is showing you how you played out annually for effectiveness, for safety, for mortality, et cetera. Okay. Where it really gets fun is in this green section. So this is where we start to plug in that what if performance evaluation. And this is where you can leverage this tool again to start setting some strategic goals around performance and say, what if we could bring our mortality O to E to below 1 for all of these metrics. So I'm just going to show you an example here. This is where it's an interactive tool. I'm going to go into that metric value and I'm going to put 1.0. Okay, you'll also see over here on this domain rank result column, I'm currently at 105. If I can move my gen med to a 1, it didn't change a whole lot. Let's keep playing. Let's move neurology to a 1. Now I went down to 103. Okay. If I move my neurosurgery to 1, I'm down to 102. So just to kind of give you an idea of setting some targets and then what that impact would be relative to your cohort. Okay. Any questions at all about this one? Okay. Another nice option is you'll notice the different tabs down here in the calculator. This percentile distribution tab is actually helpful in that what if scenario and helping you making some goal setting. Because what it does, and if you kind of can orient yourself to this document. So these are all of the metrics that we just saw in the scorecard. They're displayed a little differently. They're displayed in an alpha fashion, but these are those metrics. This first part is all about transformation, again, statistically how transformation happened for the Z-scoring. I don't want you to focus on that. I want you to scroll even farther over to these columns with the P's, P5, P10, P20. So these are the metric values for that metric stratified by the percentiles in your cohort. Okay, so your 5th percentile, your 10th percentile, you've got your median percentile at P50. And so again, most of the metrics, and I love this too, this column that says metric direction. Most of your metrics you want to be lower, right? You want your mortality index to be low. You want your readmission rate to be low. In your HCAPs, you want your scores to be higher. So this gives you that metric direction indication, but also using these percentile distributions can help you to pick a metric value that you may want to use to populate into your what if calculator, right? Rather than arbitrarily saying, let's get everything at 1. Well, what is the median in this cohort doing? And what would the impact be if we were at median performance? Does that make sense? Does that help? Have you seen this before? Okay. Yeah. So, these percentile values, I think, can be really meaningful, again, in helping with, setting some goals. Another tab I'd like to point out, so data periods. So again, we talked about the Q&A being Q3 of, in this example, we're looking at annual 2022. So it went from Q3 21 to Q2 22 were each of the periods. You will notice and that's all straightforward with the exception of when we get down, I'm going to show you NHSN. When we bring NHSN data into the CDB, there is a slight lag, okay? Namely because you have 90 days to report your NHSN, right? You have a quarterly deadline after it's due to CDC. Then Vizient goes out and gets that data, and then we do that algorithm of matching, all that kind of stuff. So just the way NHSN data comes into the CDB, we're always kind of a quarter behind. And so we address that in the Q&A metrics too. So you'll notice the data time frame is slightly different. we actually start a quarter earlier for those NHSN metrics and end a quarter earlier, but it's still looking at a 4-quarter year performance. So that data period is always a nice kind of resource as well. So again, I'm going to go back to the calculator. So we did the what if performance evaluation, kind of looking at if we changed up those metric values, what would the impact be on our domain score? And then also it does also change, if there was impact, it would change your overall score ranking as well. Okay, so it changes your possible ranking here when you start to plug and play those numbers as well. And then the very last section is it's a target performance evaluation. So instead of saying, what if I changed each metric, it's more like, you know, what do I want my target ranking to be? And again, at the very top here where I'm in the box where there's a target ranking of 1, it defaults to 1. So is it realistic that in a year's time frame, your organization is going to move from 106 to 1? Highly unlikely. I love that you would want to be inspired to be such, but highly unlikely. So setting realistic goals around that too. Do we want to see a 20% improvement in our overall rank? You know, do we want to get to 85 in the next year? So we can plug in, you know, that overall performance. And then what that does is over here on this far right column is it shows you then kind of based on an algorithm of that and based on where other members are performing in those metrics and looking at the highest performers, it's telling you these are what we're suggesting are your top 10 opportunity metrics to focus on if you want to move from 106 to 85.
That's what there's the confusion is, because when it suggests those, it's not actually aligning to, like when we go into the details, it will have like PSI. We don't have so it's not actually the biggest opportunity, it's more aligning, right? And then the person is that right.
Yeah, because it's taking into account those other, it's really looking at your performance in relation to the other hospitals and not, yeah, kind of from a more global view. So yeah, so again, it's kind of more a suggestion. I think there's a nice explanation in the FAQ document. I don't know if you've dove into that much, Bobby. I think there's a good kind of explanation there too about kind of how to best leverage those top opportunities that, you know, use them as a suggestion, but these aren't hard and fast. Like this is going to move you to this. It's such a dynamic, right? Right. That's probably the most important thing, right? Is everybody's working to improve, right? So even though we've made huge strides in our identified opportunities, hopefully everyone else is, and not to sound Pollyanna, but then that's great for healthcare, right? Then everybody in the country is getting better healthcare. And so that's, you know, kind of the Pollyanna way to look at it. But let's see. Any other questions? Let me open, just for demonstration purposes, I'm going to open Edmund's calculator just so you can see the difference in the numbers of service lines. So again, we've just got those 6 service lines: cardiology, gastro, gen med, neuro, ortho, spine, and surgery are being evaluated for mortality for the community cohort. Now, another thing that's really important, I'm going to go back and open OU Med Center's calculator. So remember I showed you all the hyperlinks, straightforward. There we go. There's a link. We're going to get down to a couple that don't have a link. Okay. Your NHSN CAUTI, sir, I'm hovering over it, but nothing's populating for a hyperlink. Again, that's because that's a SIR file that we can't put in Builder. We're getting that file directly from NHSN and populating it. Additionally, your hypoglycemia in insulin use. Okay, I'm going to click on that. It's going to give me an error, and that's as intended. It's not an error. It's that a template doesn't exist for that because that data is calculated. Vizient folks that create the metrics and the calculators are able to pull the raw data on the back end and write SQL queries around all the parameters that are necessary to meet that, you know, the warfarin and INR and the hypoglycemia and insulin use. there is the ability, and you probably know this, Tennille and Bobby, you have the ability to also pull the raw data out of Vizient. You can do a raw data download. And so you're not working in the CDB tool itself, but you're pulling, let me stop sharing this ugly server error message. You can pull raw data and have all that raw data, but just know that it's only as good as the folks that you have available to write reports using SQL to kind of mirror that methodology. So there are some limitations in that not all metrics can be recreated in Builder. Majority can, but not all. And again, like your HCAPs, you wouldn't be able to drive any of that over. So most, but not all. And then what will happen from the calculator, you'll just see that you can't link to anything. In the template section that Dorothy showed you earlier when we were doing readmissions, under Q&A, there would just not even be a line item for that thing, because those templates are really only anything that a template is available for. Thoughts or questions or anything else that's kind of bore out of this discussion? Yeah, let me go to Report Express.
Period, they did not have PSI 6, so whatever the top opportunity is, right? Or was it the top opportunity? Yeah. When they drilled down, they didn't have case with PSI 6.
Yeah, it was one oncology.
Okay, so you had no events.
Yeah.
Okay. So I mean, another way to interpret that is to continue having 0. Like that's still, it's not necessarily an opportunity, but that's, if you continue to keep that at 0, that's going to keep driving you towards that goal. Is like, that's a top weight, maybe? Is that fair?
With Christina is based on the ranking that your target ranking and kind of where that falls.
Okay.
Not necessarily.
Yeah.
Okay.
But whoever was in that spot.
Who was in that spot?
But I
Okay.
haven't looked at
So maybe they're 0 too. I know they might be
likely.
0.
Likely.
Two.
Yeah.
0.
I'm in that FAQ. And I think that is what can the target performance portion of the calculator do for my organization? Designed as part of Vizient's plans to promote the idea of proactive insights. And then how do you define the order of importance in the top 10 opportunities column? So I think there is some kind of language around that, maybe that will help, Bobby. Okay.
It's just the top 10, probably they have 0, so that's why. Because it's comparing to
This performer.
yeah, like the number 1.
Yeah. So it's kind of using all the tools available to you for finding those opportunities, right? So maybe that is, maybe a better option is looking at that percentile performance distribution and saying like, what is the median performance in this cohort? What is their metric value, and kind of calculating from that regard. Yeah. And then you said for peds, you don't have a calculator at all?
No.
Okay. Yeah. All right. And is that already being looked into? Do you know? Yeah. It is. Okay.
And it will look at until next time, or is there another update?
That's what they said first, and then, yeah, I think that first, but, and then it seemed like they, one of the meetings we had with Christina, and she said, well, you should have had it by now, like, with our last update, so they're still looking.
Oh,
I'm gonna just look on that cohort list to see.
Also, yeah. The volume, I think for the 10th percentile, it's 0 from 10th to 45th. The value is 0. That's why. So Bobby, when I looked at that percentile distribution in your oncology calculator, the PSI 6, they're all zeros until the 45th percentile.
Okay. So we're just saying that like, that was, if I'm understanding, that is like the highest weight contributor for that section. And so that we would need to keep that at 0 through. Is that what we're saying?
Yeah, because actually not 50th. So you would exactly what you did. You looked at that, and then you look in the percentile weight and see.
Not even
both
listed in that
0.
cohort. So we have to.
But how you even would interpret that? So if we look in it and see, okay, we don't have opportunity in this, that just that
Keep it
that
at
right is saying it's super highly weighted, so keep where you're at. That's
We had changed the one to be like, 600. Would it populate something at that point? Because at that point it would be.
Probably like 60. This is
Okay.
that 60th percentile. So let's look. I'm gonna do that. I'm there now. So
You want me to populate 60 in this one?
I think you have the Q&A. I mean the CMC. I have the oncology.
Oh, got it.
So I can open that then, Schierer, and I can. Yeah, so it's the web, it's the one it's then what is it again?
So it's like a firewall thing with whatever server you're on.
Okay.
Yeah.
It's just taking me to.
With all the cybersecurity stuff and macro-enabled workbooks, and so many places are locking down the ability to download a Excel document through firewall protection. So,
But I literally just set it up. If I just set it open.
Wait, was that
so is it like
before
bouncing you
were
between?
on- Before you were
And I said,
listening?
no.
Is everyone else able to get to theirs?
Yeah,
Yeah,
right now I haven't tried it yet, but we did have another coworker who, and everything he was trying to download,
We're taking to.
we took him to a website that, like, he just couldn't get anything, like, couldn't get anything. Even somebody who sent him the Vizient one, but then I was able to send it to him.
So do you think that's an internal firewall thing, or is that a Vizient?
That's what we were thinking.
Okay, okay.
Because what's weird is the fact that it goes back to my dashboard. So like my landing page, rather than coming up to like one of those error,
Oh,
firewall error.
oh,
That, I think that's weird.
yeah. Yeah. Okay, so 11:27, we have till noon. I'm happy to cover set my preferences, alphabetizing the by variables. If folks want to go through that, it sounded maybe like that was a kind of a, yeah. You can alphabetize. So it depends which drop-down list. What we can alphabetize is your selection for your group by variables at the top of a report builder. So we can alphabetize those, but not the report type. Yes, that one's always going to be, that's hard coded that way. Unfortunately, yes. Yes, but in the next section over to the right of that in your I want to look at. So let's do that, unless there's any outstanding questions about Q&A. Do you feel like that was okay? All right. Okay, awesome. And again, watch for our announcements about our analyst cafes, because it really, so our job as product advisors and being on the delivery team is really just to translate their work, their methodologies, their resources, their tools. And so we're, here to kind of help you understand it, but the why behind it, the rationale, all very valid questions. Well, why did you choose this PSI and not that one? And they really are our source for the rationales. You're right. I can do that. Not it. Yeah. They're smart people. They're brilliant. They're data scientists. They're statisticians. So they are good at what they do. All right. So I am going to, let's just reorient everybody back. Let's go in CDB. Let's go to our home page. So I'm going to click on the home tab of CDB. And again, I've got my screen really enlarged, so your configuration might look slightly different. Up at the top in your top right corner, you'll see these hyperlinks, and there's something here called Set My Preferences. And way back when, if you did orientation with us, we do cover this just briefly and get you kind of set up. Set My Preferences is where you can set your own personal default settings for within the tool. Whatever you set here is just for you. It doesn't impact anybody else in the organization. It's just your user preference. And also just know that whatever you set as your default can still be changed on the fly. So for example, if I'm setting 2022 here as my default risk model, but when I'm in Builder, I want to switch to 21, you can just use the radial button to switch. It's just merely what is defaulting when it opens, okay? So again, if none of you have already, if your fiscal year is ending in June, you have the ability to change that here. So that way, when you're in Report Builder and you say, by my fiscal year, it will attach to your fiscal year. You can set your default hospital. So I knew I was demoing here today, so I set OU Med Center. If you always are working with children's data, you can set children's as your default. You can set admin as your default. We often get asked about custom lists. I created a diagnosis code custom list in Builder, but now I want to edit it. I want to change it. I want to delete it. I want to do something else with it. You're always going to want to come back to Set My Preferences to do that. And so again, this Manage Custom List area, you have to use the drop down and find what custom list you created. So for example, compare hospitals. If I made a custom list of compare hospitals and now I want to edit that, I just select that one and I can edit it from right here. I can say, oh, you know what? I no longer want, you know, so kind of like that PEDS list, you can manipulate that way. And then you can also share it from here. Right underneath, yeah. So those are the options. You could create a new one here. You can edit a current one you have. You can share, you can delete, which I sometimes do. I have some old custom lists based on old cohorts or things I can delete here. And then honestly, I don't know what refresh. I think it's just refreshing this page, but okay, so what I really wanted to show everybody though was that alphabetizing your managed group bys. Okay, so I'm down here now in this report section. So everybody with me here where I'm at report. And then you'll see a drop-down menu. And so like I was explaining to the ladies that had to leave, you do have to do this for every report type. So alphabetizing them for a patient outcomes, non-inpatient will only do it for that report type. So just know that. So you can use your drop-down menu. Again, these are all the different reports available for you to build in Builder. So for example, I'm just going to say, let's pick non-inpatient patient outcomes. And then I'm going to click this manage group by. Okay, a new window will open. It's taking just a minute to load here.
Is it matter of time? What did you say?
I did patient outcomes non-inpatient, which was the first one at the top of the list. Yeah. And so what you'll see on the screen, and then when yours loads, so on the left side are these new available. So actually, I haven't updated mine. So since I was became a Vizient, got Vizient, these CCSR became available. So I'm going to add those. You probably, it's blank for you because yours are already added. So I'm going to go ahead and just move those over and add them. So this isn't the alphabetization part. This just shows you, if you ever go in here, if there's some variables you don't have available in your pick list, this is where you can add them in. Okay, so now you'll notice over here, I added them, but those came in at the very bottom of my list. Everything else was alphabetized, but those new ones I added are down here. Okay, I'm going to expand this, make it big. What we're going to do here to alphabetize is sort ascending. So think alphabetize ascending, right? So sort ascending basically moves everything into alphabetical order. Okay. So now they're alphabetized. The only caveat that we give to alphabetizing, and this is where it gets just there's a little manual work involved here. When you run most of your basic reports, if you're not segmenting out by payer type or physician or DRG, and you just want to look at it at the facility level, you always want to have hospital system as your variable. That's your first column you want to see, okay? So Vizient recommends after you've alphabetized using the ascending option, you take this hospital system option, so highlight it. So we've highlighted hospital system, and we're going to use this move up function, okay? I wish I could click and drag and move it to the top. It's just not how the platform was built. So apologies for that. It feels clunky, but it's just how we do it. So now you'll see that everything is alphabetized with the exception of hospital system, because that's what we want to always pop in that variable as a first option for you when you're running your reports. I'm going to click save. And so now that will give me a message that I've saved that. Should give me a message that I've saved that for this report type only. Then you have to do that for readmissions. You have to, what my recommendation is the reports. So now I got the saved okay message. Your reports that you're going to be running primarily, right? So maybe do this, as a starting point. If you have the time, do it for every single one now, if you want to, and just have that. But, minimally do a patient outcomes and do a readmissions. But this is the steps you take to alphabetize those group by variables. So let's just do one more. Let's do readmissions. Again, mine is probably already alphabetized. So you select the report type, and then the button next to it is manage. I'm going to manage my group by variables. We'll give that a second to load. Again, I have those others available. Yeah. And then sort ascending for alphabetize, ascending. And now we have them alphabetical, but we want to use that hospital system as always our first option to pop in there. So we're going to click on it, highlight it, and then move it up. And there it is at the top of my pick list. Okay. I'm going to save within this window, and just know we're only saving within this window. At the very bottom of Set My Preferences is another save button. You must hit that last save button to apply all these default selection changes. So once I get my okay that this saved, it brings me back out to my main Set My Preferences page. I will say too, you can change your standard restrictions. So again, if you're always running pediatrics reports and you want to include only your pediatrics, the conversation yesterday, some of you might have already left for the day. Vizient defines pediatrics age as 18 and under. I'm sorry, under 18, 17 and under. It's under 18. Okay. So if I know you were telling me yesterday that you've got sometimes patients that are over that age in your children's. If you've got that filter selected, you won't see those patients because it is age, it's an age-based clinical flag application. But anyway, my point being, you can set some of these as your defaults if you would like. You don't need to. But again, no, in the tool ad hoc, you can make a change on the fly just by clicking that radio button. Okay. The very last option is down here at the bottom, save. So we want to make sure we save it. Vizient says you've saved that successfully. So now when I close this window, this set my preferences window, and when I go into Builder, for example, patient outcomes, you see it's already populating hospital system, because again, that's the first column we're going to see in most reports. And then when I click my drop-down menu, though, everything else is alphabetized for me. Same is true for the readmissions one that we just did. Hospital system is always a first choice. Click on the drop-down, but everything else now is alphabetized for my options for pick list.
Not to be like this, you know, originally.
Honestly, the truth is, as these variables were added from a, I've been asked this before, and so what the developers said, it's just as it's however they're added into the tool is how they appear on that pick list. It's almost like a chronological thing of how they've been added. So yeah. Great question. Again, out of my scope of like development and software development, but that's. Yeah, it is curious, right? Why wouldn't they just automatically? And it's something to do with how they were, they were created chronologically and how they've been added in, over the years through the tool. I will tell you all too, we're undergoing a huge transformation from a development side that the UI refresh is coming in the next couple of months. We expect to see CDB is going to look a lot different. The look, feel, the data is all going to be the same. The functionality and building reports, it's just going to look a lot different. So a little more. I know, right, where the Campbell soup aisle is, right?
Is there a way to set your default for your hospitals, your focus hospitals?
Yes, that's in set my preference. There's a focus HCO option.
So I see focus hospital systems expanded a lot.
Oh, the system. I'm sorry. I thought you meant focus hospital.
The focus hospital, I'm not seeing it. Maybe I'm just HCO.
HCO, healthcare organ, default HCO.
yeah.
Sorry. Yeah.
Thank you.
All right. Yeah.
That's also why they say passwords. Because we should be nice.
So what do y'all think? We're down to our last 20 or so minutes. Happy to answer any questions unrelated to what we covered the last 2 days. There's CMS, some templates for CMS that have stroke. Yeah.
For readmissions and mortalities, those are both in there,
Yeah.
but not like the sideline.
Oh,
Yeah.
Unfortunately.
So the another really common question we get about Vizient data. So if you think about how the data comes in, right? Coding, billing, administrative billing, process metrics, you're not going to be able to get out of Vizient, right? Process, when we talk about a process like, can't think of a relevant example right now. MedRec at discharge, right? We don't have a way to capture that in billing data. But the utility of the tool at least can help you isolate the population, isolate those cases, and then that can at least give you a smaller group to go in and do your deep dive chart audit. What did the EMR say we did at discharge as far as education? Did we give smoking cessation to our smokers? Did we?
She may already know this. I just- Comprehensive stroke center and your group.
Yes, I believe. Yep, in Profiler, I'm pretty sure in Profiler, let me go there. So in Report Builder, there's that link in your Compare Hospital section for that link to help me decide using Hospital Profiler. Can I move my thing out of the way here? I'm going to expand that. So if we look at Profile Feature, this is general. If we go to Features, here's your stroke certified. And then you can look and say, I want to look at only those hospitals that are stroke certified. If I scroll down, you'll see I have a huge list here. I'm going to change this to yes. And then now they're listed. I have edit buttons here. You guys won't see those. That's this is all though self-reported. Okay, we don't go in and we trust, you know, that folks are honest with their, you know, how they're identifying themselves, but this is self-reported.
Is there a reason that there's not
Metrics.
an NDQ level 4?
You're looking for the UNC.
No, it's not an option.
Oh, oh.
Interesting. I don't know that. I'm going to write that on my list of things to follow up on. NICU level 4.
See, I don't know, because I don't know, they said, thank you.
Right, right. I came from a hospital where we sent those babies out to the NICU level 4, so I wouldn't have ever even looked at it.
When we went in and we set up our file, that was an option to select.
I don't think it was.
Oh, was it not? I thought it was.
That was why I was wondering, because I think we maybe picked level 3 because that's the highest
Because there
option.
was-
Highest option. So did that help about with your stroke certified? Yeah.
If you look at stroke mortality, you need to look at, comprehensive stroke centers, because they're gonna be high.
Yeah.
So are we high compared to them?
Right, right.
Is- is-
Yep.
Did you
And
find it?
I didn't know it. What was your?
you've got us, use us. We're here to help. Yeah. And then you send it into us. Yeah. You send it into us in.
There are other people who made these reports. The collaborative shares. Under the shop. Yes.
Mhm.
You can like have them set up so they run.
So schedule is a bit of a misnomer. You can't schedule a cadence like I want this report to run every Monday morning at 9 a.m. That's not what scheduled refers to. Scheduled is the tool telling you, look, you're running a really large poll. You're running 50,000 case profile details. I'm going to run this in the server on the background so you're not watching orange bubbles spin. And then I'll send you an email. The tool is going to say, you've got an email now that your report is ready. And then you go in and find it in that scheduled report section. So yeah, there's not the ability to set a regular cadence.
But can you save a report? Like, I can build one
And
then
save it.
and then I can go back in every Monday.
Into your, yes, like on your calendar, have a calendar appointment to say, run that report. And at least it's saved with the criteria you used to build it. Mhm. Yeah. Yeah. Can I just do a gut check? Were these 2 days helpful at all after having the virtual orientation and at least being able to talk it through? Okay, good. Good. Excellent. You know, COVID changed all of our worlds, right? This used to be a hospital would implement, we would show up. It was only a 4-hour on-site. We would only do 4 hours, if you can imagine that. We didn't cover readmissions. We just covered the basics. And then we were here, you know, through our support line. And so then COVID hit and we pivoted to everything virtual. We created more content. We made it 2 half days, but we recognize too that the virtual world is not always ideal. Sorry, those of you on Zoom right now. We did our best to keep you with us here, but so coming on site to help address questions is always helpful.
That was the missing piece for that. Because I attended lots of the But as we were trying, and buddy talking through it, but as we're trying to figure out, okay, now how to do this. Wow, this is-
Yeah. Yeah.
That's really good.
Right. Right. And being able to read the room, right? I can see when people are struggling, like, let's slow down, let's pause. You lose all that in the virtual world, right? You do. So we recognize that. And, as of now, I think we've created a pretty good model for virtual delivery for the most part, but we're still adapting and flexing too.
You had more interaction in the first two levels.
And I have
The level learning, yes. I have a new employee that just shared that with me too.
I'm telling you, it did not help until I got to that third.
Yes,
I was lost.
So 1 and 2.
Yeah.
yeah,
I know, why didn't they?
yes. I'll give that feedback to our education team. So that's a team that partners with us that are really trying to do some new innovative things with technology. We've just moved our provider insight information. So we didn't even talk about provider insight, but that's our new platform for OPPE workflows for provider reporting. And we moved some of that into an LMS system so that hospitals can track and say, like, almost like your own, whatever platform you use to say, okay, here's your certificate that you completed. And you can, as a CDB coordinator, see who's what attended what. And so, yeah, that's all coming. Eventually, all those learning levels are going to be moved into that type of a platform. I don't know about content change. Again, those education teams are kind of, that's their wheelhouse, but we give feedback based on.
It's just,
Yeah.
it's so overwhelming. Listen to all those and then you're thinking.
Oh, no.
Also the readmission stuff.
I felt like I had more so
Than the other two. Yeah.
All this like foundation information and how you apply it, where you go, and what we do.
Yeah. I have a new staff member. She was a ER nurse, did some quality, but she's we don't really have a formal onboarding training. It's on the job learning and self-paced learning. And she's like, level 3 is great. I wish everything else. So we give that feedback that you are giving. Yeah.
Let's see, so it's not just general.
Sure.
Like,
Yeah.
But.
Sure. Yeah. Well, I have to be honest, this has been super fun for me. This is my first on-site visit since fall of 2019. I was in Texas at a hospital in 2019, and until this trip, I've been behind a computer screen in my home office for all these years with members. So people still exist. It's so nice to see friendly faces and people eager to learn. And even like the questions, we love the questions. We even love the mistakes and the frustrations, because that helps us learn how to teach better and how we can help you. So we appreciate everything. And again, hopefully. Yes, ma'am. Yes. Yeah. 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 Yeah.
But by the time I got to the end, I think the thing took me, I went to 270. And it's really get more, they put the like details.
Yeah.
Yeah. I had busy days.
That's great feedback. I'm going to go ahead and log off Zoom. Do you think anybody on Zoom have any? Thank you, Zoom participants. Sorry if I was not directly asking you for questions either, but we appreciate you joining us and zooming in.